Hello and welcome to this session of the Center for Podiatric Education. In this session, I'd like to speak about a subject that's very close to me, something I've had tremendous interest in for quite some time, and an area that I think has gone largely unexplored in wound care. And I'm speaking about the subject of compounding of topical medications for the modulation of wound healing. I think that if I had a theme for this discussion, it would be to be process-oriented rather than product-oriented. All too frequently we care for wounds and we try to decide what product or what dressing should we prescribe that would best benefit the patient, rather than looking at the wound and saying, what would I like to accomplish with this wound at this time, and how do I best accomplish that? So I'd like to review the indications for topical compounded medications to assist in wound healing, and looking at the individual components of wound healing compounding that one can use. Compounding became very popular in medicine in general, including podiatry several years ago. Unfortunately, the benefits of compounding were overwhelmed by financial considerations, and we had questionable relationships between doctors and compounding companies, stock options, investments, percentages, all sorts of schemes that led to abuse, and as a result, a lot of the insurance carriers backed off from covering compounded medications, and I think that was unfortunate because underneath all of the financial concerns, there were tremendous benefits to compounded medications for wound healing. So we still have compounded products available. We still have many compounding pharmacies available. And in prescribing these, it's important to talk to the patient about the fact that they likely will be responsible for a percentage of the payment. But we're dealing with wounds. We want these wounds to heal. The patients want them to heal. And when appropriate, I think compounding offers us some tremendous benefits. As podiatric physicians and as physicians who are MDs or DOs or physician assistants or nurse practitioners who deal with ulcer management, this list probably represents the most common ulcers that we encounter. Probably venous ulcers would be statistically the most common, decubitus ulcers, ulcers with arterial insufficiency, the mixed arterial venous ulceration, and of course diabetes related ulcers, and then ulcers related to hypertension, ulcers related to connective tissue disorders, and so forth. And looking at compounding, the ultimate benefit of compounding is that it allows you to look at that wound and look at that patient and individualize care and determine what that particular patient requires and obtain for the patient the required medications, the required topical therapy, and not be restricted to what's available. Do I just pick collagenase? Do I just pick a topical antibiotic? Do I just select a hydrogel? When we can combine all of these agents as needed into one compound in order to achieve success. We look at the recent enthusiasm for assessing the exact nature of the microbial inhabitants of various wounds, spend a good deal of money doing that, and then devising individualized preparations of antibiotics in order to reduce the bioburden load in these wounds? Well, we can apply the same principles to wound healing. We want to always remember that topicals, whether they are compounded or individual agents which are prescribed, are adjunctive therapies, and they're used with other appropriate therapies for the management of a wound. And we don't depend solely on topical therapy for ulcer management. So in looking at prescribing, compounding, and wound management, the question is, what do you need in a particular patient? Do you need antibiotics? Do you need antifungals? Do you need pain relief? Do you need some stimulation for healing? Do you need debridement? And oftentimes we find that pre-made products don't provide us everything that we need. And again, we find that we're forced to select a product and attack a process rather than looking at the ability to accomplish multiple things at the same time in a particular wound. Because ultimately what we want to do is heal that wound. So compounding offers us site-directed therapy. Obviously, we're applying this directly to the area of need. Compliance is easier. Instead of having to apply more than one agent, we can combine multiple agents in one cream or ointment or lotion, and compliance becomes easier. And ultimately, if we're able to heal the wound, we save a great deal of money. And if we're able to just prescribe one medication rather than multiple medications, particularly when they are in generic form, here again we can substantially reduce the cost of wound care. Now, sometimes people ask about the use of drugs in an off-label manner, and the reality of it is that the federal government does not regulate the manner in which approved drugs are utilized, and so it's totally appropriate and totally within bounds, if you will, to utilize approved agents topically to achieve wound healing. So you look at each patient and you say, what do I need to accomplish? How do I manipulate that wound? And what do I put into that topical to manipulate the wound to the patient's benefit, rather than looking at that patient, looking at that wound and saying, well, what product am I going to choose? So we can truly individualize care for each patient. And again, we want to remember this is adjunctive. So looking at wound care in general, we know that in wound care and wound healing, we see a series of individual tissues, individual cells, which should appear sequentially in that wound. So initially we have bleeding and platelets, and then we have neutrophils and macrophages and endothelial cells as vascularity increases, eventually fibroblasts, and ultimately epithelialization. So that in normal healing, we have a sequence of events that result in a series of cell types that appear and then disappear due to some regulatory mechanism, which is driven by growth factors and interleukins and matrix metalloproteases and so forth. And we study these and look at deficiencies in various populations, such as the diabetic patient, and we attempt to drive wound healing by provision of various components. We may impart into that wound, install into that wound fibroblasts, uncommitted mesenchymal cells or stem cells, various growth factors, and so forth. So grossly, we tend to define wound healing as having three basic stages: an inflammatory stage, a proliferative or healing phase, and then ultimately maturation. But we know that this process can be broken down and is much more complex. And we also know that if we were to biopsy any particular wound at a given time, we don't just find evidence of an inflammatory phase or a healing phase or a maturation and contracture phase, but we have overlapping of cell types, overlapping of tissue types, and overlapping of healing processes at one time. And the basic principles of wound management are known, I'm certain, to all the listeners. And again, it's important to understand, as I'm sure we all do, that there's more to wound healing than just the selection of the dressing or just the selection of the topical. And we need to look at various factors that can influence wound healing, that can impair wound healing, and correct as many of these factors as we can. And a compounded topical therapy is a part of that. So looking at the use of topical agents, they are acting locally. Because they're acting locally, we have increased local concentration. We can alter the local wound dynamics. We don't have to worry generally about systemic effects. And ultimately, we can alter wound physiology. We can stimulate epithelialization. We can stimulate the production of granulation tissue. We can upregulate growth factors. We can reduce bacterial and fungal bioburden. We can increase vascular perfusion to the wound. We can achieve some degree of debridement, and we certainly can reduce pain. So when I look at an individual wound, I say to myself, which of these factors do I wish to, what do I wish to achieve? And if I wish to increase vascular perfusion, I can do that topically. If I wish to achieve some degree of debridement, I can accomplish that topically. If I want to reduce pain, again, I can accomplish this topically. And we've seen a tremendous interest and explosion of technology in topical therapies, be they application of cells, growth factors, mesenchymal cells, and so forth. And I would argue that we also need to take a serious look at compounding. So the use of topical agents to achieve wound healing to some extent might depend on the stage of wound healing. We could provide antibiotics, we can provide antiseptics, we could apply vitamins, we could apply minerals. So what are the FDA products that are approved for wound healing? And this is a general list. We can apply anesthetics for pain relief and also for vasodilation. We could apply antibiotics, antiseptics, enzymes for debridement. We could apply factors to stimulate granulation tissue, growth factors, moisture enhancers. And what's nice about compounding is we can accomplish many things at one time. So I could mix an antibiotic, I could mix a debriding agent, I could mix an anesthetic, I could provide factors to stimulate growth. So here's an example. I can utilize phenytoin to promote granulation tissue, and when we are at a stage when we want to stimulate epithelialization and stimulate granulation tissue, yes, we can apply skin graft substitutes, no question about it, but we also can make these skin graft substitutes more effective with the application of phenytoin, dilantin. We can use misoprostol, which has been shown topically to accelerate wound healing. We could use antibiotics. For example, we could use topical metronidazole, and here again is a perfect example of compounding. We may have a wound that has an odor from a buildup of anaerobic bacteria. Rather than separately prescribe metronidazole and separately prescribe, for example, collagenase, we can combine the two and achieve more than one thing at one time. It's just a matter, again, of saying, what do I need to do with this wound? What do I need to prescribe? And finding a compounding company that you can work with that can accomplish this for you. We can improve vascular perfusion, and a perfect example would be a topical nifedipine. So here again, We may debride the wound. We may want to utilize collagenase to maintain the effects of that debridement. We may want to utilize some metronidazole, perhaps increase vascularity with nifedipine, perhaps stimulate granulation tissue with phenytoin. And we can accomplish all of these things at one time by compounding. We could utilize agents such as lidocaine for vasodilation and for reduction of pain. And of course, when we reduce pain, we secondarily also increase vasodilation, although we know that amide anesthetics by themselves have a vasodilatory effect. We could use agents such as pentoxifylline, which locally applied have been shown to be helpful in management of, for example, venous ulcers, and have been shown to work synergistically with calcium channel blockers. We could utilize estrogen to increase the rate of wound healing and stimulate collagen synthesis. So you could see that we have a tremendous list of agents, all of which can accomplish various things for us in wound healing. And it's really a matter of deciding what do we want to accomplish with a wound, thinking about it, and writing down what it is we wish to accomplish, and contacting that compounding pharmacy that we work with and say, here's what I want you to mix up for me in an appropriate manner. Debridement, of course, is a big part of wound care. We want to remove necrotic and non-viable tissue, sort of create a second injury and restart wound healing. And there are many, many manners in which we perform debridement in wound care. At times, topical debriding agents are utilized when other methods are not appropriate or cannot be performed. I like topical agents for debridement to prevent the reoccurrence or development of necrotic tissue after surgical debridement. So in that regard, probably the most common agent that is utilized is collagenase. And typically pre-made commercial collagenase is found at a dosage of 250 units per gram. As you know, it removes denatured collagen and native collagen within eschars and necrotic tissue by severing the peptide bonds in the collagen. We could also use agents like urea to loosen necrotic tissue and non-viable tissue. Now, in utilizing collagenase, we don't necessarily have to go with a specific fixed product. Now, fixed products such as Santyl have excellent literature to support their use, no question about it. And it's a very effective agent, a very good agent. Its clinical effectiveness has been demonstrated in multiple studies. However, if we compound collagenase, number one, we could utilize collagenase in a generic form. That means that we probably will save money. Number two, we can add other agents to that collagenase. So, for example, we could add collagenase to metronidazole, or to other antibiotics, or to an antifungal, or to an agent such as phenytoin to stimulate granulation tissue. So collagenase is collagenase, and generic collagenase can be utilized with other agents to help achieve wound healing. Now, in addition, we can add other debriding agents such as urea or salicylic acid to the collagenase to increase the effectiveness of that debriding agent, or we could increase the strength of the collagenase, because one of the advantages of compounding is that you're not restricted to preset concentrations and preset dosages. So you may want to increase the concentration per gram of the collagenase, for example, and you could do that by compounding. What about increasing vascular supply? We used to talk about classifying ulcers as being either neuropathic or ischemic. We used to talk about ulcers as being either venous or arterial. And we know that many of these ulcers, increasingly so recognized, are a combination of both neuropathic and ischemic elements. So they're neuroischemic ulcerations. And we know that many venous ulcers are in fact a mixed arterial venous ulcer. So that in using wound care products in patients in whom there is an ischemic component, we would like to achieve additional vascular flow. And this can be done by adding to your topical compounded medication agents that will increase the vascular supply. This can easily be done using agents such as calcium channel blockers. We could use verapamil or nifedipine. We can use topical pentoxifylline. We can use topical nitroglycerin. We can use topical local anesthetics, which again are directly vasodilatory, and if the ulcer is painful, reduction of pain will reduce vasospasm, again increasing vascular supply. So when I look at an ulcer, I may want to, for example, utilize collagenase plus one of these agents to increase vascular supply. Many ischemic ulcers are painful, and here again I could add a local anesthetic plus a debriding agent plus perhaps an antibiotic or an antifungal, so I could achieve multiple goals at one time. And I think this is the potential benefit of thinking about compounding up wound care products rather than staying with a fixed product that has a fixed concentration, has only one agent, and can only accomplish one thing. We've long known that calcium channel blockers will increase circulation. They're used in the treatment of cardiovascular disease all the time, and we know that agents such as verapamil and nifedipine will decrease peripheral vascular resistance, increase peripheral vascular flow. So in consideration of the neuroischemic or the arterial venous ulcer, you may want to consider adding agents such as calcium channel blockers or pentoxifylline. Similarly, lidocaine or bupivacaine, these are calcium channel blockers. They increase blood flow by direct vasodilation. They also increase blood flow by decreasing pain and thereby secondarily reducing neuropeptide release and inflammation. So they decrease pain, result in less vasoconstriction, which in itself reduces pain and also increases blood flow to the wound. So rather than just prescribe just topical lidocaine, I could utilize topical lidocaine, plus I could add an agent like phenytoin to stimulate healing. I could add a debriding agent like collagenase. I could add a topical antibiotic or antifungal, or I could accomplish multiple things at one time. And again, I realize this is a redundancy in my theme, but it points to the beauty of compounding for wound care management. Pentoxifylline has been shown to be very helpful in the treatment of venous ulcerations. It improves red blood cell deformability. It is a hemorrheic agent so that we are able to achieve oxygen delivery to tissues that are subjected to flow through narrowed vessels. It decreases blood viscosity, again increasing blood flow, and has some anti-thrombus effect, and has been shown to be helpful for sickle cell ulcers, venous ulcers, and arterial ulcers. So here again, this is something that you can incorporate into your compounding formula together with other agents. Now, Lord knows we understand the importance of collagen. We know that collagen is the basic protein making up the majority of skin, and it forms a lattice work upon which healing cells migrate and participate in the wound healing process. And we certainly know that we have no shortage of forms of collagens that are advocated for application to wounds. Typically, we know that collagen is produced by the fibroblasts, and those corporations that make collagen products, that make fibroblast delivery systems, that make agents or dressings that contain collagen, argue that in many disease states, such as the diabetic patient, that the fibroblasts are ineffective or inefficient in producing collagen, and that we must provide collagen in order to enhance wound healing. In compounding, we can provide collagen in addition to reducing bacterial count, fungal contamination, stimulating healing, reducing pain. So collagen is one more thing that you can add to your compounding formula if you feel it is appropriate and needed to assist in healing, because we certainly have any number of dressings that we prescribe for the purpose of providing a collagen delivery to the wound. I think one of the most underutilized agents in wound healing is generic dilantin, and that is phenytoin. And there are a number of studies that have suggested that there is indeed reasonable evidence, a reasonable basis upon which to suggest that the provision of phenytoin to a wound may be helpful. And this can be utilized in conjunction with skin graft substitutes or skin grafts themselves. The interest in using phenytoin for wound healing really grew out of the side effects of phenytoin when used for treating seizure disorder, or in my early days, dilantin. As a young practitioner, we did not have many drugs to utilize for treatment of peripheral neuropathy, for example, and we were stuck with agents such as dilantin, tofranil, and tegretol, agents such as that. And one of the side effects that would be noted when dilantin was utilized to treat neuropathy or to treat seizure disorder was gingival hyperplasia. And that is because it came to be understood that phenytoin would stimulate collagen and protein synthesis. It would stimulate hydroxyproline synthesis. It stimulates fibroblast activity. It stimulates the production of platelet-derived growth factor, interleukins, and stimulates the myofibroblast. So that some people, smarter than I certainly, said, why don't we take this side effect, this sequela of dilantin, and put it to good use and try to get that same stimulation of collagen and protein synthesis and hydroxyproline and so forth. Why don't we get that operative in the wound itself? And again, this can be done by generic incorporation of the agent into the compound you're using. Now, phenytoin has another effect. It stimulates the myofibroblast, which is this transition cell between the fibroblast and the myocyte. And this is the cell that is partly responsible for wound contracture. So not only does phenytoin have the capability of stimulating wound healing, but it also has the ability to stimulate contracture of the wound and have this occur at a more rapid rate. And there's a number of papers that have looked at the use of phenytoin in various manners. This particular study was with the use of phenytoin in polyvinyl alcohol dressing, showing stimulation of the myofibroblast and fibroblast for more rapid wound healing. Another study looking at patients with diabetic foot ulcers, utilizing a combination of debridement and 10% phenytoin ointment. This was followed by skin grafting, and the skin grafts took in 100% in 12 patients, 80 to 90% in 3 patients, and 60% in 1 patient. The point being that the pre-application of phenytoin together with debridement appears to enhance the likelihood that skin grafting will take positively. And in my own experience, I've utilized phenytoin with split thickness skin grafting together with a variety of allografts and xenografts, and probably would be successfully utilized with other agents or other skin graft substitutes that are commonly utilized today to increase stimulation of wound healing. So that we want to do our debridements and graft site preparation, we generally will utilize a combination of compounded phenytoin with topical antibiotics or antifungals, and then go ahead and apply whatever type of graft you feel is appropriate for that particular patient. A number of these studies have been looked at utilizing the use of phenytoin for the treatment of diabetic foot ulcers, for various decubitus ulcers, and the typical study, phenytoin versus phenytoin and standard therapy. They've looked at the use of phenytoin in this particular study with Duoderm and just triple antibiotic, and again, superior outcomes with the use of the phenytoin. Phenytoin has also been looked at for venous leg ulcers. Now, phenytoin is a generic, so no one's going to come to your local wound care meeting pushing topical phenytoin because it is a generic agent. It is helpful, and it can be included in your topical compounding in wound healing. So I would ask you to seriously consider the incorporation of phenytoin as part of your compounding in the treatment of wounds. And again, any number of these papers are available that show, as concluded in this particular paper, that topical phenytoin is effective, inexpensive, and effective in the treatment of wounds. Some people are very enthusiastic about the use of Manuka honey. Again, you could prescribe Manuka honey as an individual product, or you can say, I like Manuka honey, but I'm also going to combine it generically with some other agents. Again, perhaps an antibiotic, an antifungal, perhaps something for pain relief, perhaps phenytoin to stimulate healing, perhaps a collagen. And as you know, it's approved for wound healing. It is said to promote tissue growth, promote epithelialization. It is said to have reasonable antibacterial properties, including being anti-MRSA. So here again, with compounding, you can employ Manuka honey, but in addition, utilize other agents at the same time. Misoprostol has been shown to be a promoter of collagen synthesis. It's an analog of prostaglandin E1, and it inhibits the inflammatory process. So in those patients that you feel inflammation needs to be dulled, then you can certainly consider the use of misoprostol. Generally, anti-inflammatories, as you know, are induced in areas of injury, and misoprostol, as well as other NSAIDs and steroids, will block the production of prostaglandins. This will lower the amount of pain that the patient's experiencing. It's been shown that topical misoprostol has been helpful in decreasing the healing time of local flaps and increasing the percentage of flaps that survive. As far as pain goes, we will not infrequently apply an anesthetic in the wound care center, but we have patients that are asked to do dressing changes at home. They may be experiencing quite a bit of pain with those wounds, and this may deter them from doing their dressing changes, from cooperating with the plans that we would like to have them participate in. And again, I like incorporating a topical anesthetic, most often lidocaine or bupivacaine, so that I get a vasodilatory effect directly from the amide through its calcium channel blocking effects on the vascular structures, and secondarily because when we reduce pain, we increase blood flow. So instead of just applying just a topical anesthetic, we can compound this and apply multiple agents in one. So we reduce patient pain, we reduce patient suffering, we make painful dressing changes less painful. It allows for more effective superficial debridement and increases blood flow. We hear a lot about bioburden, and we see more and more calls for the detailed genetic evaluation of wounds for bacterial nucleic acids and identification of the specific bacterial and fungal components that are present in a wound. We know that bioburden decreases wound healing. It utilizes oxygen. We have bacterial production of endotoxins and exotoxins, the production of protease, and we know that all wounds heal in a colonized state. We know that this results in impaired white cell function. We know that deep in the wound, because the bacteria utilize the oxygen, we foster anaerobes deeper in the wound. We have decreased production of fibroblasts, and reduction of bioburden is felt to be a goal in wound healing. Now here again, with compounding, we can add any number of antibiotics or antiseptics topically, so that instead of just prescribing a topical antibiotic or just one antibiotic, I can stimulate healing with phenytoin. I could try to achieve debridement with urea or salicylic acid or collagenase. I could reduce pain and increase blood flow. And in this case, we could also add topical antibiotics, one or more, and include antifungals in order to reduce the bioburden and stimulate wound healing. So that if we have a candidal component, we could add nystatin. If we have a dermatophyte that we think is causing some problems with wound healing, we could add terbinafine. And we could go broad spectrum with agents such as itraconazole or amphotericin B. There are many who are enthusiastic about tea tree oil. Its properties are said to be antibacterial, antifungal, antiviral, and anti-inflammatory. And here again, if you are a wound care specialist and you are enthusiastic about tea tree oil, you can include this in your compound. So in summary, we know that wound healing involves a sequential series of physiologic processes, from hemostasis to inflammation, to the production of vascular influx, to the formation of granulation tissue, epithelialization, and remodeling. And we know that we have a series of tissues, a series of cells that sequentially appear in that wound. We can utilize compounding to assist in achievement of wound healing. We don't rely solely on compounding, but I could look at any given wound and say, rather than what product do I want to prescribe, I can say, what is it that I want to achieve in this patient? Are they having pain? I can relieve it. Is there an ischemic element? I could increase blood flow. Is there necrosis that I want to debride? I could add a debriding agent. Do I want to stimulate the formation of granulation tissue? I can do that. Is there too much inflammation? I can calm that process down. Do I need collagen? I could provide that. So rather than one specific product that will accomplish one of multiple needed goals, compounding offers me the ability to assist that patient in more rapid healing. So hopefully you will give some thought to this concept. I think it's a good one. Yes, it is a bit more expensive for the patient in terms of the compounded cream. In all likelihood, you'll be fighting for insurance coverage. However, in the end, it's less expensive for the patient. In the end, it's less expensive for the insurance carrier. And in the end, I think there's good reason to believe this is helpful in the assistance of wound healing. I thank you for your attention and hope that this has been of some benefit to you.